Okay, thank you, John. So the talk I was given here was TTFM, what do the numbers mean? Let me ask this audience, how many routinely use TTFM at the end of a coronary bypass graft? So certainly over half, maybe approaching 2/3. How many in the audience also use ultrasound assessment in addition to TTFM? So a very significant drop in the numbers. So the talk I'm going to give, I was asked to talk about TTFM, what do the numbers actually mean? I'm going to go through this pretty quickly because I want to talk about why ultrasound assessment might also be important in addition to TTFM measurements. And I do have a very obvious conflict of interest. I act as a formal advisor to the company Medistim, so that's my major conflict of interest. Very brief background. Assessment of intraoperative coronary bypass grafts is very important. It's been repeatedly shown in the literature that there's quite a high intraoperative failure rate of bypass grafts if you look for it objectively. The problem is in the operating room is often asymptomatic. You don't get changes in hemodynamics, ECG, or echocardiograms in the operating room. But when you are at home and you get a phone call at 11 o'clock at night, you say, who's calling me at 11 o'clock at night? You know it's your hospital, and they're not calling you to say, Prof, you did a great job today. They're calling you to say, we've got a problem. And there are several recommendations about why you should try and make quality graft assessment in the operating room. But if you look at the adoption worldwide of the technology, it's extremely variable. In Japan, it's over 90%. In Germany and most of the Scandinavian countries, it's 70 to 80%. In the USA, it's said by industry to be 25%, and maybe John Puskas will comment, it's probably not that high. And in the UK, it's currently about 20%. And the question you then have to ask is, should it be TTFM alone, or should you also have ultrasound assessment? Mario Godino and Mark Gruelle led this study, published in Circulation, pointing out the potential benefits of using TTFM assessment. But they did also say there is a cost to doing it financially, and there's also a learning curve to how to interpret it. And we've got several other expert speakers today, so I'm going to leave it to them to cover that. But I do want to point this out, and it's very important and it's very basic. Now, do any of the surgeons in this room ever see perioperative myocardial ischemia? See? Nobody. Because why would you use TTFM or assessments to prove you did a great job? But the reality is, if you look in the literature, from big series, so at least 500 patients, the risk of perioperative myocardial ischemia is about 4%. So these are from big, reputable studies. And what you can say is that 2/3 of the origin of those problems occur in the operating room. So if you don't identify and fix it in the operating room, that's when you get your call at 11 o'clock at night. We did this large study called REQUEST, over 1,000 patients, using both TTFM probes and high-frequency ultrasound to look at different things that can happen during coronary operations. These are the people who were involved in this study. My very good friend and colleague, John Puskas, was a major contributor. And we tried to work out how often, by using routine assessment of what's happening in the operating room, do you change your practice. We published this in JTCVS in 2020, a prospective study of over 1,000 patients. Notice that for off-pump surgery, it was 40% of cases. there was a high use of multiple arterial grafts in 43% of patients. So this was not typical of routine coronary surgery. So these were highly experienced surgeons. We looked at 4 things during that study, and these are the key messages that we found. If you look at off-pump versus on-pump, there were changes to ascending aorta manipulation in 14% of patients off-pump versus 4.3 on-pump. If you look at graft revisions, and this to me is really important, overall graft revisions were just under 5% for arterial grafts, but only 2.5% for vein grafts. And that tells you what we all know. Doing arterial grafts is technically more complex than doing vein grafts. But again, I emphasize, these were in the hands of high volume surgeons. So my suggestion to the audience would be that if you looked at a wider community, these changes might be even higher. And if you look at the territories that were revised, the highest revision rate was to the inferior territory at 5%, and fairly similar for anterior and lateral at just under 3%. And that's interesting because we always say the difficulty with off-pump surgery is doing the lateral wall. But if you expose the lateral wall properly, it should not be a problem. Medistim, who promote the technology and obviously commercially sell it, they have very good online learning curves. So I was asked to talk about the 4 TTFM parameters, and we know what they are. So it's mean graft flow, which literally tells you how much flow there is in your graft. The pulsatility index, which is an indication of the resistance to graft flow, should be definitely less than 5 and ideally less than 3. The percentage diastolic flow, because most coronary flow with the graft is in diastole, and the percentage backflow always lower on the left than the right side. And these are the kind of things you would always see for TTFM findings. Your 2 observations are based on having a steady graft flow. And the 4 numbers, as I've already alluded to, are the absolute flow, pulsatility index, diastolic flow, and percentage backflow. And this is the newest version of the device, led by Medistim and particularly Hakon. And this is showing, we now have 4 speedometers, if you like, showing you what your actual measurements are and where they should be in terms of green, obviously meaning good, yellow meaning be a bit careful, and red meaning you've probably got a problem. But it's not just graft flow that we can look at, it's what does ultrasound add to what we know from graft flows. So every one of us can recognize in an operating room a heavily diseased, calcified aorta. You may have preoperative information already indicating it. But let me ask this audience, how many of you with a very sensitive finger can palpate endoluminal aortic disease? So, if it's not grossly obvious, every time you manipulate that aorta, it is a bit of a risk. Now, it may not be in a 40 or 50-year-old, but in an 80-year-old, manipulation of the aorta is something you have to be potentially very careful of. And if you ask an 80-year-old, if you say to them undergoing coronary bypass operation, there is a 1 to 2% risk you will die from the operation, they will accept it. If you tell them there is a 1 to 2% risk of having a devastating stroke, they won't accept it. And this is why, as many of us in the aortic or coronary surgery have promoted, is the importance of a no-touch aortic technique. So this is what you see if you get things right with epicardial ultrasound. This is what you want to see. A lima going to the LAD with good anterograde and retrograde flow. But as I said when I started this talk, the problem is, and the reason that perioperative myocardial ischemia is important, is that in 2/3 of the patients, the problem is in the operating room, but if you don't detect it then, it's too late to do it several hours post-operatively. So let me just, in the last few minutes, show you a very few examples. This is a right internal mammary artery to the intermediate, and nobody is going to question, is there a problem with your graft? And if you look at this with ultrasound, it actually tells you what the problem was. So this was a rema to the intermediate, which to the surgeon's initial view looked like a perfectly competent graft, but there was no flow in it. And on further inspection, the surgeon felt there was a twist to the IMA graft to the intermediate, so the graft was revised, and you can see an immediately change in flow. But the point of this was, if the surgeon had not imaged that graft, they would have felt that technically it had been a perfectly competent graft. Here's a second case again where there's no problem. Lima to the LAD, there's clearly a problem. Very low flow in the graft. When you image, so the question then is, why do you have such poor flow in that graft? So ultrasound imaging showed what the problem was, that the toe of the anastomosis was blocked, but there was still some retrograde flow. And it is surprisingly easy to either have a block to the toe of your graft or to the heel of the graft, but you will still have some flow, anterograde or retrograde. But if you hadn't imaged the graft, you would not have been aware what your problem was, and this was this graft revised. So we've got a number of very highly experienced surgeons in this room. So you've done an IMA to the LAD, you've got a flow of 17 mils per minute and a pulsatility index of 1. What do you do? Dr. Trahan, would you be happy with that graft? So what would you do?
No, we don't have ultrasound available, but that is could be a great addition to really. But if you have a 15 millimeter, you said?
17, yeah.
17 millimeter, it should be over 20 at least.
It should.
Yeah. So I would maybe revise the graph.
I see Dr. Steve Freems looking with a quizzical look on his face. So Dr. Freems, what would you do if that was your graft? Okay. How many people in this audience, based on that information, would accept that result and be happy with it?
It depends. I would wait and repeat it.
Sorry?
I would wait a little bit and repeat it again.
Okay.
Get the pressure up and see whether this improves, because the PI is low.
Right. So the technical decision is, as Dr. Trahan said, you would normally say if the flow is below 20 for an IMA, you'd be a bit concerned. I never like to see an IMA with a flow below 20. So I look at this, but then I think the pulsatility index is very low. So the question is, who would look at this and then say, I'm going to revise that graft? Dr. Trahan would revise it. Who else would revise it? Dr. Puskas?
I don't like 17.
No.
The PI of 1 is a pretty good number, but we're used to much higher flows than 17 on most vessels.
Dr. Asai?
Usually when the flow is 17 and you're thinking it's okay, it's because the PI is 3.5, and you know that was a moderate stenosis in the LAD, and you put a graft there knowing that it was going to face competitive flow and not expecting a flow of 57 or 117. If this were a large LED with a tight proximal stenosis, I would not accept that number.
Dr. Asai?
I think we see this continuous waveform here, but the 17s compared to the PI 1.0, very abnormal.
Yeah.
So I would really like to take a look at the echo. You have echo, MiraQ type of things.
So without the echo, you've got to ask yourself.
But before talking about that, we need to make sure the blood pressure adequately high, also the preload, everything, optimized.
So in our practice, we only do the measurements, final measurements, with a mean blood pressure above 80, because it's absolutely crucial. So either go for a mean blood pressure of 80 or a systolic of 120, 130. So this is the situation we've got. So you as a sergeant are now thinking, what do I do? So so the question is this graph acceptable or is there a problem? Now, when we image the graph with ultrasound, what you can see is there was a purse string stenosis of that graft. So the graft was technically patent, but when we revised it because of the purse string, you can see a very different flow measurement. And you can also see that the pulsatility index that had been previously low is even lower. So the point I'm making is we say pulsatility indices of less than 5 or less than 3. So on our initial assessment of this graft, we would have been very happy. But the point is that if you don't also image your anastomosis, you can be misled. So this is the final case I'll show you in terms of time. So this was a patient I was referred, and it was a very diffusely diseased LAD, and I didn't know exactly where to graft this vessel. Now, if the vessel had been completely thrombosed or occluded, then it's clear you do a long endarterectomy. But in a case like this where you have multiple diffuse lesions, what I decided to do, rightly or wrongly, was a localized endarterectomy, which you can see here. And I did that so that I would then have a soft spot for the IMA to the LAD. So once we'd done this, this was before we gave protamine, with a flow of 25 mils per minute, which is very acceptable, low PI, low diastolic flow, and no backflow. So who in the audience just now would say there's a problem with this graft? So nobody would feel there was a problem. However, when we did the ultrasound assessment of the anastomosis, we now suddenly saw something we didn't like. So the anastomosis itself is widely patent, good flow, but we see this flap, intimal flap on the posterior wall. And the question you ask yourself now is, does this flap affect flow, or is it an incidental finding? So who would now, on this basis, revise the graft? 1, 2. So approaching half the audience would revise it. Excuse me. Well, I decided this was probably an incidental finding, so I said, I'm not going to revise the graft. I don't think it's hemodynamically important. But then we gave the protamine, and the flow was now 11 mils per minute, and the PI, notice, still around 3. So not disastrous. But now you're feeling less happy with your graft. Who would revise this now? Right, okay? And even I agreed I need to revise this graft, because what we looked at was we could see the same image as before, still an intimal flap on the posterior wall, but I was no longer happy after protamine with these flows. So we revised it, and there you can see the intimal flap that we removed from the posterior wall. And now when we look at the revised measurements, a much higher flow, still a very low pulsatility index, and with the ultrasound imaging, you can see that the anastomosis now looks perfect. So on that point, I'm going to, in the interest of time, finish my talk. But the point I was trying to make today is even with flow measurements, if you've got a flow of 50, 70, 100, you're going to be very happy. But by doing routine ultrasound assessment of your anastomosis, you will detect issues that you did not think were a problem. And more importantly, is what do you do when you have a graft where you feel the flow is inadequate? You have to go through an algorithm in your mind. Is there a problem with my graft? Now, I don't have time to show you today, but in several of our grafts, we found that there were intimal dissections of the IMA. You usually get a hint when you see that bluish discoloration of a skeletonized mammary artery. But the use of ultrasound allows you to detect, is there a problem in my graft? And is there a problem with my anastomosis? Because if you have a widely patent anastomosis, then you can be pretty confident if you've also checked your graft and there's no dissection in the graft that this is competitive flow. Now, there are other ways you can assess competitive flow, but the addition, in my view, of this technology to not only check, do I have a good graft flow, but to check, because the one thing, I've said this before, the one thing we do in coronary surgery is if your patient leaves the operating room with a patent IMA to the LAD, you've changed their life expectancy. So if you do nothing else, make sure you've done that. Thank you for your attention.
Thank you, David. Our next speaker is Dr. Lally, who actually is distinguished in that she has published what I think is the most definitive thus far paper reporting false and negative positives in TTFM, but also linking certain metrics for flow, especially in the LAD, to survival during longer-term follow-up, which of course is a clinical correlation of the value of TTFM measurement. Dr. Lally, thank you for being here.
Thank you. Thank you for presentation. I'm very delighted to be invited in this fantastic Congress. The subject that I asked me to talk about, as explained, is the false positive and false negative in transit time flow measurement, which is a very challenging subject. There is no doubt that transit time flow measurement can help surgeon to detect the problem and correct it before leaving the patient from the operating room. And as the larger studies confirm, every time that we revise an anastomosis, the mean gradient flow improve, as you see in the lecture of Professor Taggart, and Barsley index decrease. That means that normally we can trust the number, and transit time flow measurement could be a very good modality to find the problem with the anastomosis. But in practice, it's not as straightforward as we would like, as explained sooner. As confirmed by several studies, transit time flow measurement is very sensitive to technical and physiological confounders that create many false positive and false negative. On the other hand, transit time flow measurement, even if it is very specific, it has low specificity, which can lead to false negative and resulting in missing the graft with a problem. And also it has a very low positive predictive value that can cause the false positive results and prompt unnecessary revision. So how we can get out of this mess? One of the simplest way and the first step is to eliminate the technical problem by choosing the correct probe size, by paying attention to the alignment of the probe and ensuring a good acoustic coupling index during the measurement to not have the technical problem during the measurement. On the other hand, physiological confounder is very important also. So for improved reliability of the test, as confirmed by several studies, and as TTFM is very sensitive to systolic blood pressure and cardiac output, we should have a good hemodynamic state when we do the measurement. Also, we should have pay attention to the competitive flow. Every time that the results is not good, we have to pay attention to this problem, and we can follow the flow chart that is clearly explained by Dr. Kaiser, and sometimes it can help us to find the competitive flow and not revise the anastomosis. And also the surgeon should be considered the influence of the conduit that they choose and the type of cardiac surgery that have on the transit time flow measurement results. As we see yesterday in the live case, every time that we do a minimal invasive coronary surgery, the transit time flow measurement should not be optimal because of the pressure that we have with the stabilizer on the heart. So we have to pay attention to this factor that can change the result. And as explained clearly sooner by Professor Tagar, it's very important to have the other modality that can help us when we have doubt about the numbers on transit time flow measurement. One of the best modality that can help us is high-frequency epicardial ultrasound, which confirmed that it can improve the positive predictive value of transit time flow measurement from 10% to 100%, and by this way prevent the unnecessary revision or pushing the surgeon to revise the graft. Another modality that we also saw yesterday in the live case using the indocyanate green, it is not a new technique. It's a long time that it exists, but for a long time we didn't use in coronary surgery because of its limitation in on-pump and off-pump surgery. But recently the publication in 2024 and 2025 start to revive the use of this technique during coronary surgery if there is any doubt about the transit time flow measurements numbers. And in order to be fashionable as I like, we will talk about artificial intelligence. This is a new system that could be helpful in every part. For example, for transit time flow measurement, by combining flow parameter to the patient-specific variables, that TTFM is very sensitive to that, AI can detect the nonlinear pattern that normally missed by the threshold which are fixed. And also by this combination, we can derive a new parameter which is named diastolic resistance index that can detect the subcritical stenosis. And by this way, we can reduce the false negative and not missing the graft with the problem in the operating room. AI can also combine intraoperative transit time flow measurement data with a preoperative QFR, which is defined by CT-FFR, and by this way we can stand out the competitive flow and prevent unnecessary revision. AI can also apply fast Fourier transform to transit time flow measurements analysis. By this way, it can transform the time domain signal to frequency domain signal. Don't ask me what does it mean, but they're trying to work on it, and by this way, they explain that especially for anastomosis on the LAD, when the FFR on preoperative is more than 0.75, it could be very useful, because if the FFT is more than 1, it means that there is a competitive flow and there is no need to revise the graft. And finally, I want to explain you how we decided to do transit time flow measurements in our institution in France in order to eliminate as much as possible the effect of physiologic confounders and competitive flow. Our operative strategy in our institution and generally in France is total arterial revascularization with double mammary artery in a Y configuration and sequential anastomosis. And as we do the CABG now in France, more than 80% on-pump surgery, so we decided to do the measurement when the heart is arrested. We define that when we do the measurement, when the heart is arrested, and because we do the total arterial, by the pump, the mammary arteries are perfused by the pressure of the pump. So there is not any physiological confounders that can can affect the results of transit time flow measurement. On the other hand, there is not any native coronary flow or collateral flow that can have a problem with competitive flow. So the results of transit time flow measurement is more reliable, and we can really judge that there is a problem with the anastomosis or not. We have just pay attention that when we do the measurement during arrested, normally the mean gradient flow is higher, and the pulsatility index should be lower than 0.4. It's not 0, it's lower than 0.4. This is also confirmed by another study, which is done in 2022, that they proposed that doing the transit time flow measurement on an arrested heart can help to eliminate the problem of physiological confounders and competitive flow. On the other hand, they propose, and we do also in our service, that we recheck the mean gradient flow after releasing the clamp when we have a very good hemodynamic state. If the mean gradient flow down more than 3%, then when we checked during heart arrested, it means that there is some type of competitive flow for this anastomosis, and we follow this type of patients more closely than the patients that there is not this difference for the mean gradient flow before and after declamping the aorta. We do a real study, is very small study about doing the measurements in arrested heart, and we define that the number of 0.4, which is proposed by Kaiser for arrested heart, is really exact, and we find exactly the same. If we do the compression, this is a measurement during the heart arrested. You see that the flow is 32 and PI is 0.2, and we do the compression at the distal of the anastomosis, the PI can rise up to 0.6. This is the final result that you can see. Here we start the compression, the flow and the PI would go up to 0.5 or 6. So 0.4 is the limit of PI that we can have in an arrested heart. So in conclusion, we can say a TTFM is a valuable tool to detect the problem during surgery, but interpretation of the results should be cautious and integrated with clinical judgment. We should follow the sequences. If there is abnormality with the TTFM results, we should check for the technical and physiological confounders. We have verified for the competitive flow. If still there is abnormality, if we have the possibility to check with epicardial ultrasound or indocyanate green, we have to do that. That can help to revise the anastomosis or not revise if it's not necessary. AI maybe help us to move one step closer to an objective results. And finally, I would like to mention that even if TTFM imaging modalities and AI can help us to detect, see and understand the problem, but finally it's the surgeon that decide to revise or not the grafts. Thank you for your attention.
Next presenter is Dr. Kim, Dr. Min Seok Kim from South Korea.
Good afternoon, good evening, I mean. Thank you for the opportunity to give this presentation. And I have nothing to disclose, but I have to say I'm a big fan of intraoperative TTFM and I use it every day. Surgical revascularization is commonly performed to the diseased left coronary artery territories with more than 70% of diameter stenosis, and right coronary artery territories with more than 90% stenosis. Although coronary angiography is a gold standard for diagnosis of coronary artery disease, it does not provide information on the functional significance of a stenosis. The revascularization of functionally insignificant coronary stenosis may cause competitive flow in the bypass graft. This study demonstrated that the lesser degree of coronary stenosis and competitive flow were associated with ITA graft occlusion. And I was first interested in the competitive flow, and in this past study, we have found out that the competitive flow were observed in 3.4% of distal anastomosis who received composite grafting performed post-operative graft angiographies. During this study period, however, native coronary angiographies were performed only in cases with suspected abnormal graft flow, and it was assumed that the competitive grafts could be underestimated. So in this study where native as well as graft angiography was routinely performed, 15.8% of grafts showed competitive flow on early angiograms. We defined and classified the competitive graft flow as bidirectionally competitive and unidirectionally competitive grafts. And this is an example of bidirectional competition. And you can say that there is a bidirectional competition as saphenous vein to OM anastomosis because the graft and grafted coronary artery flow are clearly opacified the graft angiography. And also the graft flow is well visualized by native coronary angiography. This is an example of unidirectional competition, and you can say that there is a unidirectional competition as saphenous vein to OM1 anastomosis because the graft and grafted coronary artery flow are not opacified by the graft angiography, because you cannot see the OM1 flow on the right side of the video, but the graft flow is well visualized by the native coronary angiography. CT-FFR has been validated as a reliable method for non-invasive measurement of FFR, and being able to provide FFR values along the entire coronary tree, including small distal coronary arteries, CT-FFR could be especially valuable for CABG patients. In this previous study, we have demonstrated that the CT-FFR values were different between the perfectly patent, bidirectionally competitive and unidirectionally competitive grafts on early angiograms, and the diagnostic accuracy of CT-FFR for predicting the early competitive graft flow was high, so it could be used for predicting a functional coronary stenosis in CABG patients. Intraoperative TTFM is known to be an easy and reproducible method for intraoperative graft evaluation, and routine measurement is recommended by the guidelines. The comprehensive interpretation of TTFM parameters can predict intraoperative graft failure. Previous studies demonstrated a correlation between the combination of TTFM parameters and early postoperative abnormal grafts. So the question was, are TTFM parameters useful for predicting competitive graft flow during the year after CABG? And which is more predictive of competitive graft flow during the year after CABG, preoperative CT-FFR versus intraoperative TTFM? In this recent study, 108 patients who had preoperative CT-FFR values and received in situ ITA-based composite grafting were included. Among the patients, 97 patients underwent one-year follow-up angiograms. Patients who were scheduled for elective CABG underwent thoracoabdominal CT angiography as a routine preoperative evaluation protocol in our center, and cardiac CT angiography was performed simultaneously without using an additional contrast material. Cardiac CT results were analyzed by a Korean software, and CT-FFR values were obtained. Among the TTFM parameters, mean graft flow, pulsatility index, and diastolic filling percentage, which were displayed simultaneously as a numerical value on a real-time screen, were obtained. And the post-operative angiographic findings were compared with CT-FFR and TTFM values of each anastomosis. Early and one-year post-operative angiogram included both selective graft and native coronary angiograms, and early angiograms revealed 33 bidirectionally competitive and 27 unidirectionally competitive and 1 occluded grafts among 342 anastomosis, and 1-year angiograms revealed 13 bidirectionally competitive and 8 unidirectionally competitive and 11 occluded grafts among 310 anastomosis. There were differences in CTFFR and TTFM values among the perfectly patent, bidirectionally competitive, and unidirectionally competitive grafts. A further analysis revealed statistically significant difference between the perfectly patent and competitive grafts in CTFFR and TTFM values on early angiograms. And a post-hoc analysis on 1-year angiograms revealed statistically significant difference between the perfectly patent and competitive grafts in CTFFR, but the difference became statistically insignificant in TTFM values. So the cutoff values of CTFFR, mean graft flow, pulsatility index, and diastolic filling percentage were obtained, and by analyzing the ROC curves of each parameters, we could conclude that CTFFR values were superior to TTFM values in predicting competitive graft flow on both early and 1-year angiograms. So the main findings of the study were that both CTFFR and TTFM parameters among the patent, competitive, and occluded grafts on angiograms taken during the year following CABG were significantly different, and CTFFR predicted competitive graft flow better than the TTFM parameters during the year following CABG. I will introduce few cases. This was 82-year-old male who presented with unstable angina, 2-vessel disease, and a left main disease. These are the preoperative angiographies. And these are the results of the CTFFR values. So the patient underwent up-pump CABG using saphenous vein Y grafts, and the D1, D2, and OM were revascularized. And as you can see, the intraoperative TTFM measurement showed a reversed flow with diastolic dominant pattern on D2 and OM anastomosis. However, the 1-day angiogram revealed perfectly patent flow without competition in all anastomosis and also in 1-year angiograms. It's another example. The patient was 56-year-old male who presented with unstable angina with 3-vessel disease, left main disease. These were the preoperative angiographies, and these are the results of the CTFFR. So the patient underwent up-pump CABG, again using vein graft as a Y graft, and LAD, OM, and PDA was revascularized, and the intraoperative TTFM measurement showed reversed flow in PDA anastomosis. As you can see, we put the PDA minus on it because we put the probe backwards. And the 1-day angiogram revealed unidirectional competition as saphenous vein to PDA anastomosis, which was similar to the TTFM findings. However, in 1-year angiograms, all grafts became patent without competition. So in summary, both CTFFR and TTFM values showed good diagnostic accuracy for predicting competitive flow during the year following CABG using an in situ ITA-based composite grafts. However, the diagnostic accuracy of TTFM values for predicting competitive flow was, I do not want to say it, but inferior to CTFFR values. And CTFFR could be used as a guide during surgical revascularization for predicting functional stenosis and thereby maintaining short-term graft patency. Thank you for your attention.
Thank you, Dr. Kim. That was a brilliant presentation of a very complex and sophisticated analysis. Thank you for that. We're going to move right on, though, because we're running a little late. Donna Kimalarajuk, I hope I didn't mutilate that too terribly, Donna. Is a wonderful coronary surgeon from the Cleveland Clinic. Beyond the numbers, integrating TTFM into surgical decision-making and post-operative strategy. We're delighted you're here. Thank you.
Thank you so much, Dr. Puskas and Dr. Taggart, for having me. And thanks so much for being here, everyone. So talking about this flow probe and how we use it as a tool and how it guides my decision-making, I really came across this quote that I thought was really applicable. It's all the tools, techniques, and technology in the world are nothing without the head, heart, and hands to use them wisely, kindly, and mindfully. And this is by Rashid Ogunlaro, who's a life coach, motivational speaker. And I think that's really applicable when using this little guy. It's a great tool, but I think we need to know how to use it accurately, and in the right context with other variables that we're going to talk about. And so when I read through the MediSim guidebook in preparation for this talk, this was on the first page of that large manual. Although TTFM does not guarantee that grafts will stay open for a prolonged period of time, we certainly believe that grafts that are occluded at the time of surgery will continue to stay occluded. And I think that's really how I use this flow probe to guide my decision-making intra-op, or I guess early post-op. And it's already been kind of touched on in previous talks that if we know that there's a problem with the graft, we can usually trust that poor read. It's a little trickier when it's maybe borderline, or you think it's a good graft and maybe it's a false positive. So just as a reminder, and we've seen this already, and you've all seen this intra-op, when we're looking at that read on the screen, we have our mean flow, the PI. Of course, I'm looking to, like, do I have good contact with my probe, my acoustic coupling index, and then if you have the diastolic filling percentage and your ECG. Of course, this is not new to any of us. But when I'm looking at this and I'm measuring flow, which I do for every single anastomosis in every single case, when I'm first looking at mean flow, what am I looking at if I'm looking at a great number or a not so great number? Okay, the MAP, which we've talked about already. We want a MAP above 80. My practice is off pump, but sometimes I do on pump cases if you're doing valve, maze, or aorta. You've just taken the clamp off, your MAP's low, or you're just come off pump. Okay, well, let's jack up the MAP. The size, the quality of the graft. Do I have a good match between the flow probe as well as the size of the graft? Was it a really big vein? And we don't have, yes, it does happen. We don't have the right size probe because it's not clean yet, or what have you. So, okay, that's going to affect my interpretation. The quality of the native coronary artery. We've all been there where you find that one soft spot that you can get on the PDA or the OM or the LAD, and you have nowhere else you can go really, or you're not going to do a full endarterectomy for whatever reason. You have to consider the quality of your coronary artery. Also that distal runoff or resistance. Those terribly controlled diabetics that, again, have a really small distal runoff, or women with really small arteries, that's going to affect my interpretation of, well, I landed where I could. I know there's poor runoff. Spasm of the arterial graft, blood velocity, and air bubbles are all going to affect that read. So these are things, are kind of part of that algorithm that Dr. Taggart's talked about, that I'm thinking about when I'm first looking at mean flow. And then next, pulsatility index. Again, that's going to be affected by anastomotic narrowing, distal stenosis, distal thrombus, twist or kink of the graft, poor runoff, and competitive flow. And so we'll talk about how I look at these with some of my cases. I didn't include them. I didn't want people thinking I can't operate. So you never take photos of the bad ones that you have to revise. But also looking at diastolic filling, so it's going to be higher on the left side due to higher pressures. Your back flow, it's going to be affected by your severity of stenosis, so competitive flow, and steal from other vessels, i.e. if they had subclavian stenosis. So taking into consideration, or looking at all those variables on the screen when I'm measuring, my decision-making starting point is, was it a good target or a poor target? Again, we've all been there where the targets, it is what it is, right? You can't change that sometimes. So good versus poor. And then same with my conduit. Am I happy with the mammary? Was I concerned maybe in one part of the lima, was there a bit of bruising, or was the vein not stellar and this was the one piece of vein we could get? I've already taken BEMA to try to graft everything else and I only have vein left for the right, and this is what it is. So this is rather simplistic, these next couple of slides, but this is, again, my algorithm or decision-making tree. So we'll start with good flow, because that's easier. Good flow, low PI, we're happy. Okay, great flow, we're getting out of the OR, no issue, I'm not concerned. And again, though, maybe, as we're seeing, we can be fooled. Maybe I got a actually ultrasound, which I don't routinely do. But with TTFM, if I'm pretty confident, good target, good conduit, yeah. Good flow, borderline PI. This may represent some spasm, poor runoff, or competitive flow. I may wait, I may spray some vasodilator and recheck. I may revise, because we'll talk about the other variables I look at, but it's kind of that art of that decision-making, the art of you knowing your patient and that distal. Good flow, high PI, I'm a little more inclined to consider revision. And again, we'll talk about some of the other variables that I'll look at. Now the tougher parts, the poor flow scenarios. Poor flow, low PI. This, again, I think we've already talked about, someone mentioned, they would wait. I would wait too. Maybe there's some spasm, maybe the pressure's a little low, see if that's gonna come up. Plus or minus vasodilator. I'll either use nitro or milrinone, depending on what my anesthesiologist has, to inject into the vein. I've done that a couple of times where I knew I was pretty happy with that vein graft, a big anastomosis, big target. What the heck's going on? Why is there no flow? Inject that, things open up, you've got flow. Plus or minus revision. Again, poor flow, borderline PI. Wait, maybe it's spasm, maybe it's poor runoff, maybe there's competitive flow, maybe I'll revise it. And then poor flow, high PI, that's really indicative to me that there's a problem. This absolutely, every case I've had this, I've ended up revising, whether it be I've had a kink in a graft. When I did a repair stitch, I checked poor flow. Okay, the repair was too deep, take it out, do it a little more shallow, better flow, better PI. I've had a graft do a 360 on me. I've had to then cut it end to end and put it back together. Or if there was concern with, actually once a graft I put on backwards. It was very early in my career, they marked it wrong. So things like that, if poor flow, high PI, very clear, there's a problem. But the other things I'm gonna look at, the other variables, putting it all together, the conduit length. So if you've done your graft, you're pretty happy with it, you don't have that luxury to cut it back another centimeter because it's gonna be tight, okay, maybe I'm stuck with that. Or in one scenario it was under tension, so I had to do vein interposition on my vein to extend it, again, very early in my career. So I'm gonna consider that. The conduit orientation, I've had a graft twist on me, so again, you're gonna visually inspect that. I thought everything looked great, I was really happy with the anastomosis. Ooh, it was totally twisted, okay, let's fix that. Questionable quality or injury to the conduit, this is something usually you identify, or I think you identify before going on pump or before doing your distals. We have trainees that we train to harvest mammaries. It has happened that it has been injured, and so I can either extend it with REMA or with vein to cut out that injured part if it's in the mid portion, which is always not my favorite, but it happens. So again, these are things I try to anticipate and address beforehand, but you're gonna consider that if you have not so great flow or maybe a borderline PI. Anastomosis purse string or kink, again, I'm gonna think of this. Most of my practice is off pump, so I tend to tie under tension, so I'm less worried about purse stringing, but I have had a kink in the graft after a repair stitch that I had to then fix. And so there's a whole piece of the puzzle, I think, or puzzle pieces to consider when I'm looking at this flow probe measurement and thinking, okay, how's it gonna affect whether I revise a graft or not, or if I'm happy with a graft. And as many of you know, there was a systematic review by a lot of folks who are in this room, expert opinion on the papers looking at TTFM, and they had 10 statements of their recommendations, and this is number 10. And this really guides my practice, or I agree with it. The decision to revise the anastomosis should be based not only on TTFM reading, but also on the clinical scenario and the surgeon's assessment of the conduit and the target vessel. And so very briefly in the last minute or so, post-op management, if I have, a borderline flow, borderline PI, but I have nothing else I can offer them, they've got no more conduit, I've got nowhere else on that darn PDA or RCA that I can put a graft, I am going to target higher maps, really try to ensure great flow through the mammary, through the conduits. If it was a calcified artery or I see there's disease distal to it, low, again, I do off pump, so almost all my patients are getting DAPT anyways, but low threshold to put them on Plavix, which I know a couple of my colleagues also do. In the couple cases where I've had a patient struggling, where again, I was not as confident about one of those grafts, and I think, okay, there's nothing else I can offer them by taking them back to the OR, I've sent them to the cath lab to make sure that those grafts are open. If there's EKG changes, wall motion abnormalities, low threshold, and again, if it was a case, I'm really happy with that graft. I've had one case where there was concern, maybe the lean was down. I brought him back that night. It was fine. The flow was fine. They actually were bleeding. It's really putting that all together where I'm thinking, okay, that graft should be great. Why is there an issue? Is there something I can fix? I'll take them back. If it's something I really can't, I really struggle and I need help, then cath lab plus or minus PCI. So I think we've got the kind of take-home message, or my thought about this is it's a valuable tool, but it's still just one piece of the puzzle. And I think really that art of decision-making and experience comes into play in how you use this tool to help guide your decisions in the OR. Thank you so much.
Thank you very much. And this concludes what I hope we all agree has been an excellent session.